Thank you, Beth, for the introduction, and thanks to Dr. Sharma and Kinney for inviting me here to talk today, to our supporters for the conference, and of course our participants for joining us here today. These are my disclosures. So today we'll be talking about a machine called Cardiohelp, which is a small ECMO machine. And before we talk about this, I just want to kind of show you the history. This was the first ECMO patient that survived in the United States in the 1970s. And what you could see from this picture here is that the equipment needed to do this was large. It was burdensome. It required a very, very specialized team to operate that were at the bedside 24 hours a day. And it worked, but it was not plausible that other hospitals or centers would be able to replicate results like this because of how resource intensive it was. And over time, the technology has rapidly evolved such that all of that equipment that you saw in the room in 1970 has been shrunk down into a single portable machine that can be lifted with one hand that's about 15 pounds, that does all the work and the equipment that you saw in that room. And for this reason, many people are using this machine more commonly than was used in the past, and more specialties are utilizing this technology than were in the past. And like I said, it's because of this machine called Cardiohelp, which I just call a mini ECMO machine. And you can see on the screen here that the machine is very small. And the reason for that is that they were able to shrink the technology that was needed to operate this circuit. And also they were able to shrink the equipment, which is the pump and the oxygenator, which is necessary to run the machine, into a single unit, which you see at the bottom right-hand side of the screen, which is called the heart-lung system, which does both the work of the pump and the oxygenator in a very, very compact unit. So just to go back and define what ECMO is, so ECMO stands for extracorporeal membrane oxygenation. And what it is it's using a pump and an oxygenator outside of the body, which is extracorporeal. And it does three things. It removes carbon dioxide from the blood, it adds oxygen to the blood, and then it pressurizes that blood and returns it back to the body so that it can give blood pressure support. So there's two different ways that an ECMO circuit can be set up, regardless of the machine that you're using. One is called veno-arterial and one is called veno-venous, and we abbreviate them by the first initial of their words here. So veno-arterial ECMO is abbreviated VA ECMO, and veno-venous ECMO is abbreviated VV ECMO. So these are two pictures here that show the way these circuits work. So what veno-venous means is that blood is coming out of a vein, going through the machine, which pressurizes it, oxygenates it, removes carbon dioxide, and then inserts that blood back into another vein. Which vein it uses is not as important as the fact that it's going from one vein to another vein. The second type is called veno-arterial ECMO or VA ECMO, and what that means is it's taking blood from a vein, putting it through the machine that adds oxygen, removes carbon dioxide, pressurizes it, and as opposed to VV ECMO, which returns it back into another vein, this returns it back into an artery. And I'll talk about the implications of that in a second. But what VA ECMO does, because of the way the circuit is set up, is that it replaces the work of both the heart and the lungs. So it's able to give respiratory support and hemodynamic support, meaning it replaces blood pressure and the squeezing of the heart. So times that you would see this used in the Cath Lab or elsewhere is most commonly cardiogenic shock, pulmonary embolism, which causes an obstructive form of cardiogenic shock, which is effectively treated with this technology, ECPR, which is a technique that Henley mentioned before and one of the fastest growing areas of VA ECMO, and protected PCI, so times that you would do very, very high risk PCI in the Cath Lab, and we'll talk about some specific situations where this might be more advantageous than other support devices. So VV ECMO, on the other hand, because it's being reinserted back into a vein, and when that blood goes back through the vein, it still has to go through the heart and is dependent on left ventricular function to squeeze the blood into the body, it replaces the lungs only and gives only respiratory support, which is still very helpful, but doesn't really have a role in cardiogenic shock. So the times that you would see this, and we have done in the Cath Lab, is severe ARDS and pneumonia, so very, very commonly used for severe COVID-19, but also situations where people would have a hard time clearing carbon dioxide, not just getting oxygen. So things like severe asthma exacerbations or severe COPD exacerbations are also times this technology can be extremely helpful. So Far more commonly, the machine that we're used to using in the Cath Lab is Impella. So this is different than that, and I just want to highlight 3 things that I think make it distinct. One is that it provides much more support than Impella. So Impella CP, at least, which is the one that we most commonly use through the groin, this gives 3.5 liters of support. VA ECMO, on the other hand, can give almost double that support at 7 liters per minute, depending on what size cannulas you put in to use the device, so much more support. As opposed to the LV Impella, which only supports the left ventricle, this device supports both the right and the left ventricle. So when you have someone who's very sick in cardiogenic shock, sometimes it's not just their left ventricle that's affected, but it's also the right ventricle. And when you need to support someone with both ventricles down, you need either this device or the combination of 2 devices, like Henley mentioned, to give support to both sides of the heart. And this is the only device which, if you have concurrent lung issues, which you may have from a patient who's very sick, maybe in pulmonary edema, from an acute MI, or maybe from an aspiration during an emergency intubation, and you need to be able to replace the work of their lungs by giving oxygen and removing carbon dioxide, this device can do that while the Impella family cannot. So the equipment that's necessary to put this device in is also different. So on the left-hand side of the screen here, you see cannulas that we use to return blood back to the body. So we call this arterial cannulas. And when it's used for VA ECMO, they are inserted into an artery, which is why it's called arterial cannula. These cannulas are very short, but they're very big in terms of bore. So you select the device, the size that you want to use based on how much blood flow you think that the patient needs based on their body size and situation. But generally, we use anywhere from a 15 to a 19 French. The venous cannulas, on the other hand, are bigger. They're longer because they're meant to go high up in the body from the femoral vein. They're multi-stage, which means that instead of just having a hole at the end of them, they have holes along the side of them to promote better drainage from the body. And these are very big, 21 to 27 French that go into the vein. So what is the role of this device in the Cath Lab? Well, anyone who's worked in a Cath Lab for long enough knows that, complications in the Cath Lab are inevitable. We do high-risk procedures that involve, the heart, so bad things happen sometimes. So we need to be prepared for dealing with those situations. And this is a great device to use to rescue from a cath complication, either to be able to fix it percutaneously with a PCI technique or as a bridge to surgery for getting the patient down to the operating room for more definitive correction. Sometimes after myocardial infarction, Impella support is not enough, and this is a device that you can use to make sure that the patient is adequately supported while the myocardium is recovering from getting blood flow back from a PCI. There are also times where we do very high-risk PCIs where maybe Impella is contraindicated. So Henley mentioned very clearly in his last talk that when there's a blood clot inside the left ventricle, because of the way the Impella pump operates, it could suck clot from inside the ventricle and then spit it into the aorta, which can cause embolic complications, including stroke, something we obviously don't want. So in situations like that, using ECMO instead of Impella to support a high-risk PCI makes sense. And then also when patients are very, very sick, maybe for instance they're having recurrent or persistent ventricular arrhythmia like fibrillation or tachycardia, it's very difficult to do a PCI with intermittent or continuous CPR. And using a device like this can replace the entire work of the heart so that you can stop CPR even if the heart is fibrillating and do a PCI safely and effectively. So I think that many people consider this a surgical tool based on the history of the way that it was developed and used. But more and more now we're seeing the benefits of using this device in the Cath Lab rather than in a surgical arena. And I've listed 4 reasons here that I think that's the case. And one is that in the Cath Lab, we have a lot of tools for dealing with cardiac arrest. We have fluoroscopic control, and I think we take that for granted, but it's a very, very important tool. We have the ability to immediately intervene for a number of different situations that would have caused cardiovascular collapse. And with the advent of structural heart, we have more experience now with large bore closure. And one of the hardest things with this device is not just putting it in, not just managing the patient, but then safely removing it from the body without causing a vascular injury. And we have a lot of techniques now that we can do that with in the Cath Lab without involving a surgical cut down. So in terms of treating cardiac arrest, we have a lot of tools to do that in the Cath Lab. One of the ones that we use very commonly is the Lucas device. And the Lucas device has been designed in a way that enables us to do PCI with chest compressions. Again, I think it's more effective to do it with ECMO than with this, but we're used to using this machine. We have it available. We have staff that are very experienced in using it. and it is a great device to use as a bridge to getting onto ECMO and maintaining blood flow while you're doing that. Fluoroscopic control is something that I mentioned that we take for granted, but sometimes these devices are put in blindly at the bedside with no ability to see where you are. And as you can imagine, when you're placing lines that are as large as these, if you can't see where you're going, sometimes you're going to go in the wrong spot. And if you go in the wrong spot with something this big, it can cause a really big problem. So seeing exactly where you are is hugely advantageous to minimizing complications that come with putting this device in. So on the left-hand side here, you can see a picture of the wire that's in the vena cava and going up into the IJ. So you could see exactly where your wire is, make sure that your cannula is not coming off the wire and it's being positioned in the correct spot. And on the right-hand side over here, you see the cannula after it's been placed with the wire and the dilator taking out, and you could verify that it's at the appropriate height for the patient, which is necessary to get the flow that you need when you're using this device. Probably the most important thing is that in the Cath Lab, we have the ability to immediately intervene to reverse the conditions that cause cardiovascular collapse to begin with. So certainly one of the ones that we're all familiar with treating is acute MI, which you see as a picture here on the left. We can do immediate PCI, and there's been very, very good results with doing immediate PCI on ECMO following cardiac arrest. And more now in the Cath Lab, we're also seeing the ability to intervene percutaneously for pulmonary embolism. So what you see here on the right is a VA ECMO-supported pulmonary angiogram and suction embolectomy, and this can be done very easily in the same setting as putting ECMO in the Cath Lab. And like I said, in the advent of structural heart, we have many closure techniques now that we can use to safely take this device out without putting the patient, who's often very sick, through a surgery like a surgical cut down to remove the device from the vein and the artery. So ProGlide or PerClose is one of the devices we use very commonly to do this. And there's also new devices that are being rapidly developed. One of the ones that I have pictured here on the bottom right is called Manta, which is, for those of you who have used AngioSeal, is like a very, very big AngioSeal. It goes up to 18 French. So we can use this also to close the hole from the artery that was made when the cannula was put in. But also, as Henley mentioned, I want to emphasize the same thing, that while it may seem simple when describing concepts, the complexity of managing this system, implementing it, and removing it cannot be understated. So it's a highly resource-intensive and specialized tool. And whenever used, it must be done at a tertiary center with a team of providers who are experienced in managing cardiogenic shock. And we have a very robust cardiogenic shock team here at Mount Sinai, which always involves these disciplines which I've listed here, which are interventional cardiology, cardiac critical care, advanced heart failure, and cardiac surgery. So very, very important to have a team who's used to taking care of these patients and experienced in doing so. So with that, I'll conclude. And again, thank you for listening, and thank you for having me here today to speak. So.